get there.
Thank you, Pramod.
I'd like to call upon Dr. Mallika Goyal to speak on complications and results of vitreous surgery for proliferative vascular diseases.
I'd like to thank Dr. Lalit Verma and Professor Tiwari for this opportunity, and good morning to everybody. So I'll be speaking on the prognosis and results of vitreous surgery in vascular retinopathies. So what are the main problems? They relate in these cases to ischemia and the bleeding, which is perioperative and postoperative, persistent traction if it has not been tackled, and sometimes continuing fibrous proliferation postoperatively, continuing dysphysically. So the problems that relate to ischemia are that you have a thin ischemic atrophic retina, which can be associated with multiple atrophic breaks, many of which cannot even be seen very certainly, and severe macular ischemia compromising the postoperative result, and postoperative neovascular glaucoma. So frequently you have a retina like this, where you are not sure which part of it has breaks and which is just thinned out, and you have to treat the entire it has breaks. And very often we see patients with CRVO or other severe ischemic conditions where the visual result is not good. Sometimes we get a surprise in terms of neovascular glaucoma after surgery for these vascular problems, and it is reported to be about 7% of the eyes developing within a year after surgery. And so to prevent this, we have to start even before surgery. A good iris examination in patients, particularly who have not been treated with laser in the past, there's no history of treatment, and they're presented with vitreous hemorrhage. And even gonioscopy for these eyes that have not been treated with laser to rule out new vessels or anterior synechiae. And if possible, in all these patients, it's best to do as much laser as possible pre-operatively. Most commonly, the only way possible is with the laser indirect ophthalmoscope, because we can go peripherally and the illumination is more strong to allow laser. So as much laser pre-operative as possible. And if it's not possible, then use an anti-VEGF pre-operative to cut down the bleeding per-op. During surgery, as much laser as possible should be done on the table, and in case, for whatever reasons, if the view is not good and it's not possible to do laser, these are the patients who will be at very high risk for going into neovascular glaucoma post-operatively. So in these cases, it is mandatory to use an anti-VEGF at the end of surgery if you have not been able to do laser for whatever reason. At least this anti-VEGF will protect the eye for the next few weeks, 2 to 4 weeks. Also good to add anterior retinal cryotherapy if peripheral laser is not possible, because of the vitreous skirt, or you want to preserve the lens. Anterior retinal cryotherapy has several advantages, some of which have been touched upon. It reduces the peripheral ischemia, it helps clear residual vitreous hemorrhage, reduces fibrovascular ingrowth from sclerotomies, and prevents recurrent vitreous hemorrhage in a large number of cases. The risk comes down by to 1/3. This is done typically most anterior retina, just behind the ora. Now, very often we do see patients who present with neovascular glaucoma, but they may have an open angle, and in these cases, just cutting down the ischemia with extensive endolaser and anterior retinal cryotherapy, both of which will work on a long-term basis, and anti-VEGF, which will work in the short-term period. These will be enough to take care of the neovascular process. However, if you already have extensive synechiae, then you also need to take care of the high pressure apart from ischemia, and in these cases, you could add titrated cyclodestruction, and by titrated I mean you can do maybe a few degrees, say 180 degrees of cyclodestruction, either photocoagulation or cryotherapy, or which is preferable is a glaucoma shunt surgery during the vitrectomy or post-operatively. And a shunt helps in these patients because there is a tube which has an open lumen and is not affected by the regrowth of new vessels or proliferation in the angle in the future. And repeatedly I have found that trabeculectomy alone, even with mitomycin, fails in these patients. And this is a patient, I now send my patients post-operatively to a glaucoma surgeon in LV Prasad. These are the slides she has given, Dr. Vanita, and this is my patient which she has operated after the vitreous surgery. Again, a patient who has shunts in the anterior chamber after the vitreous surgery. These are patients with neovascular glaucoma, but they now have very good vision. And this is a patient, she said that she sometimes used this shunt in the sulcus rather than in the anterior chamber. When the AC is shallow or where there are too extensive synechiae, then the success improves if the shunt is not in the anterior chamber. And these patients do very well after shunt surgery and extensive anterior synechiae. Bleeding is another problem during surgery, and again happens mostly when the patient has never had laser in the past and is presenting de novo to you. And it is very important to prevent bleeding because attempts to remove clots during surgery, especially from detached retina, can be disastrous. And what are the pre-operative measures we can do? I think this we have already discussed. If laser is possible, do it. Not possible, anti-VEGF should be given to improve the visual result. And I do find that antiplatelets definitely worsen the prognosis and the surgical experience. And maybe for 10 days or 7 days, if not 3 days, antiplatelets should be stopped in vascular retinopathies. I'm not talking of rhegmatogenous retinal detachments or other situations, but in these cases, it's important. Very important is to look for anemia. I've found that these patients who have anemia also are more at risk for going into neovascular glaucoma, apart from bleeding more during surgery. Platelet counts also may be a problem. Blood pressure is very important, stabilized blood pressure. And many of these are on dialysis for nephropathy, and it's very important that their dialysis is finished at least 24 hours before surgery so that there is no heparin during the surgery. I also ask sometimes for heparin-free dialysis post-operatively to prevent persistent or recurrent vitreous hemorrhages, and that helps, definitely helps, in my experience. There is some debate about ongoing antiplatelets not affecting the prognosis, but there are conflicting studies on this issue. And many studies have shown that the risk of persistent hemorrhage, because once the bleeding starts, it is much more dense if the patient is on antiplatelets, and so persistent hemorrhage is almost 3 times more common if the patient has been on these drugs, and the reoperation rate is double than if he was not on these drugs. Silicone oil is injected if there are breaks during surgery or pre-operatively, and in these patients, even if there is no oil emulsification or the AC is not shallow, even then raised IOP is quite common for indefinite obscure reasons, and we should be prepared for removing oil very early, even at 2 weeks sometimes, because of high intraocular pressure. And more important in these patients to have an iridectomy to prevent this problem. And sometimes when you want to leave the oil because there is some amount of traction which cannot be released, then you have to use oil which you know will not emulsify soon because you want longer term tamponade. And we know from our experience sometimes which oil emulsifies later, which brand is emulsifies earlier. So use those longer, the oil that will stay stable longer. These are less common, but also problems is we remove the epithelium sometimes to improve the view, and then the epithelium doesn't grow back easily. There is persistent defects for months, and they sometimes require a bandage contact lens. So it's important also to prevent oil coming into the AC, because we may be planning to leave the oil for longer in these patients. And because of many of these complications, some of these are blinding, it is also to know, it is important to know when to observe rather than intervene. That's also equally important. And if there is a reasonable chance of stable vision, that chance should be given to the patient, but that requires frequent monitoring, and also media should be clear to be able to make a decision like that. For these patients, it's not necessary to intervene, and probably good laser and monitoring should be enough. But there are other cases like these where, of course, surgery is required. And these are the few slides to show where Sometimes you have to leave peripheral traction to be, this is a non-eyed patient actually, but she has ambulatory vision because of the attached macula. The other option was to remove all these membranes and risk complete and total loss of vision. And another patient who has a good vision now in the macula, but the periphery has all this. Other eye of the same patient, but had extensive rhegmatogenous traction detachments. So, thank you.